Okay, so the next presenter is Dr. Samuel Smith from Sierra Leone. He's the director of the National Malaria Control Program there. And Dr. Samuel Smith has been, prior to joining the program, was working as a district medical officer. And for the past 10 years, he has served as an associate lecturer for the Department of Community Health at the University of Sierra Leone. And he also held the position of external examiner for the School of Community Health Sciences for Community Health and Clinical Studies at Nyala University. Previously, he was presented on malaria for the London School of Hygiene and Tropical Medicine and the World Health Organization. In the past, he represented Anglophone West Africa in the Rollback Malaria Case Management Working Group, and he's a current member of the African Federation of Public Health, National Laboratory Technical Working Group, and the Sierra Leone Health and Biomedical Research Group. And he's going to talk to us today on his experience during the Ebola epidemic and the use of MDA for malaria control in Sierra Leone. So, please, thank you.
Thank you very much for the brief introduction, and good afternoon, everyone. I would like to share the topic titled Using Mass Drug Administration with ACT for Pregnant Women Response to Ebola Epidemic, the Sierra Leone Experience. So my outline will be in this format through the impact of the EVD on malaria intervention, the rationale for actually implementing mass drug administration, and the results, and also specialized maternity Ebola treatment center that was actually established by MSF Spain, and lessons learned. Of course, Sierra Leone malaria is really endemic, and it's perennial seasonal, and it was actually heavily hit by Ebola. And of course, EVD as well is highly infectious, which actually had negative impact on the use of RDTs and also the injectables epidemic of severe malaria. Ebola also actually exposed the weak health system in our context, and near actually collapsed the entire primary healthcare system. And Sierra Leone, it happens that we have one of the highest maternal and child mortality rates in the world. This is just showing, based on the last demographic health survey that was conducted in 2013, the under 5s 156 per 1,000 live births, and maternal mortality 1165 per 100,000 live births. Malaria and pregnancy, of course, is one of our strategic interventions, as outlined in our strategic plan. But we are using the platform of the focused antenatal care, and malaria and pregnancy is fully integrated into the mainstream, especially at the service delivery point. So a pregnant woman actually gets a package from the ANC, including the malaria commodities, the SP for IPTP 3+, mosquito nets at first contact, case management with quinine first trimester, followed by ACTs second and third trimester, and also augmentation with the other package. For the use of bed nets, just a trend analysis for the past 2 surveys conducted in collaboration with ICF International give us technical assistance. The pregnant women in 2013 were 47%, and 2016 that was conducted after Ebola, June, July to be specific, 44%. slight reduction. And that's what actually for households. For those that actually have access to the nets, it's 76 to 75%. These are the preliminary figures, and the MIS will be released hopefully by December. And the IPTP also is on the high side. For IPT1 and IPT2 plus, 71% from the previous MIS 62%. Sierra Leone experienced the first outbreak of Ebola virus disease in the eastern part of the country, to be precise, on the 25th of May 2014. Since then, the Ebola outbreak continued to ravage the country, and as of the 17th of March 2016, when it was officially declared eradicated by WHO, a total of 8704 confirmed cases of Ebola, 3589 confirmed deaths, and 221 health workers were actually killed, including 11 doctors, and over 4,000 Ebola survivors. And we actually analyzed just the Ebola outbreak on the impact, of course. The outbreak actually threatened to reverse some of the gains we've made as a ministry, as a government, and of course, and partners. Health workers were really overstretched. Some had to actually leave their usual work to work in Ebola holding centers. The supply chain was also under pressure. Competing prices were given to the Ebola commodities, PPEs, and the like. And of course, initial report also suggested that there was underutilization of the facilities because people were frightened to go to the facilities, and also the healthcare workers were reluctant to treat because they don't want to be to get healed of the Ebola. Then reduced health-seeking behavior, and of course the mistrust was still on the high side in the health system. Then as WHO guidance came out, temporary suspension of diagnostic microscopy and RDTs, fear of contracting AVD. This slide just the fear of being actually is showing us the impact of Ebola on antenatal care, 4+. Percentage change from May to September. This was a study that was conducted by the Ministry of Health and UNICEF, the Sierra Leone Health Facility Survey. So there was a reduction nationally, minus 27% on ANC, Pentar 3, 21%, deliveries 23%, and the children who are not actually utilizing our services, 39%. And of course, it's gladly showed the district where the Ebola was somehow the hotspot. The initial clinical presentations of Ebola are very similar to malaria. I mean, these are fever, fatigue, anorexia, headache, vomiting, and joint pains. So it was very challenging and posing a problem of differential diagnosis for both the patients and also the health workers. And even looking at 3 days analysis from the laboratory, 60% were actually negative. It's telling us that basically most of these could be malaria related. WHO came up with the guidance. This was the last updated on the 17th of November. Guidance on temporary measure, control measure in Ebola affected countries. So it's telling us really what to do where areas heavily affected by Ebola, why to rapidly reduce malaria morbidity and mortality, and also how using in terms of selection of the drugs. Ideally, long-lasting ACTs are not used as first line. Then the ACTs as the first line. Then, of course, who targeting the total population. So the rationale why we actually did the mass drug administration in this context because of poor access to malaria patients to health facilities, fever in patients seeking health in informal sector because they were scared to actually go to the formal setting, not to be labeled as Ebola suspect. And malaria patients labeled as EVD cases, Ebola suspect cases, and of course, at the initial stage, insufficient quarantine train capacity. So we had to actually come up with a task force to plan. We had 6 weeks to plan, mobilize the required resources, and proper implementation. That was by mid-October to end of December. We had to come up with the proposal. We had to negotiate with DFID to procure the drugs. MSF came into play to support 2 districts, Western area urban and Western area rural, that actually accounted for 60%. And also Global Fund. Luckily, I was in Geneva attending the malaria RBM task force. So I met Professor Alonso, Bossman. So all of us went to even Global Fund to ensure that the supporters are reprogrammed because we needed the commodities ASAP. So we came up with a proper macro plan, the district chiefdom micro planning, logistics planning, mobilization, training, and of course, we also ensure that supervision was actually enhanced and monitoring to give us high quality campaign, high coverage, and outcome. And importantly, a well-planned communication strategy is vital in this context because there already mistrust in the system. So it was very important to use a robust strategy for the uptake of the services. The goal of the MDA was really to contribute to the containment of Ebola outbreak in the country, thereby reducing morbidity and mortality, with 2 clear objectives: rapidly and significantly reduce malaria transmission and related morbidity to 2 rounds, and rapidly reduce the number of Ebola suspect episodes requiring testing and isolation in the Ebola holding center, but not as an objective or long-lasting impact on malaria transmission or contribute to the malaria control. That was not our objective. So these are the targets: 85% to be administered, ASAQ targeted, and 85% to actually comply with the prescribed doses. And 100% population know the benefits of taking the anti-malaria commodities. In terms of selection, we had to come up with criteria. First of all, to identify the Ebola hotspots in the country, where we have high malaria prevalence, and also the availability of the commodities that we actually were able to mobilize at that point in time. So all of these were used. So the slide on the left is really the 2013 MIS, where the northern part we had the highest malaria prevalence, the 5 northern districts, and also the map in the middle. The gray area is really talking about the MDA targeted districts. It actually corresponds with the high malaria prevalence. And the last on the far right is the MDA targeted chiefdoms versus what we use during the rapid impact assessment for the non-MDA. But that's not part of the objective of the symposium. So I'm not going to that. So the drug of choice, we had to actually use ACTs because it was well known at that point in time, efficacious, no local resistance, and the health workers were already trained because there was no time to train people. So we had to really go in for the ACTs that we are using in our first line, the ASAC or the artemisinin amodiaquine. These are the strategy. The mass administration for a 3-day course, targeting the hotspots, cover all age groups above 6 months, sorry. So the first MDA, we targeted 2.5 6 million people. And the second, we had to adjust the population because there was basically under quantification of the commodities because shift and drift in the denominator, and we're actually using the 2004 census projected population. So there are 3 million. So we excluded below 6 months malnourished or pregnant women for the first trimester were excluded. But the point is, of course, no testing was done to confirm whether the woman was pregnant or not. But the point is, with the ANC, we have our TBAs. They are also giving out SP in the communities, and most of them were part of the process. So, and also, as someone earlier mentioned, the ivermectin being distributed by CDDs in our country. So most of them, it's well known. They know how to actually probe and to know when there is quickening or not. So all of these were used. Of course, the door-to-door, the directly observed treatments was actually observed during the second phase. We missed that out in the first. Then the no church policy was very, very critical. Then 1 month apart because of the protection of the ACT. So this is the summary report. The number of houses visited were on the high side, and sick people in household, 0.2% in the first phase, and the second cycle, 0.9. And 2.2, these were actually some of those that were actually excluded, and the pregnant women were part of that number. Then the awareness was a high side. Then the ITN, we actually probe whether they are used yet because we're also promoting the use of the bed nets. Unfortunately, we distributed 3.4 million bed nets in June 2014. Ebola actually struck in May. So these nets were actually out there in the field, supposedly hung over the sleeping spaces. So we actually promoted, especially pregnant women, to make use of the bed nets. And of course, the compliance was 76% in the first phase and 3% in the second phase. But the first phase, DOT was not actually considered. But after the first phase, we were advised by JMP to actually factor the DOT because, fortunately, Professor Alonso and Pedro Alonso and Bosman, they were actually in Sierra Leone. So they advised us to factor that into the Tallinn document. So the pregnant women are excluded. So 0.4 nationally and 0.2 for the second phase out of the 2.2 and 1.2. So Potloko was, because these were actually the hotspots, Potloko, Cambia, Bombali, and Tonkalele districts. So the cost of the MDA, the Global Fund supported 6 districts, and MSF actually supported the Western area urban and Western area rural. So the anti-malaria drug cost was estimated at 0.97 using ASAQ in Sierra Leone. Delivery cost per covered person per round, 0.51 USD in Sierra Leone, ranging between 0.29 and 0.65 across districts. In the 2 districts supported by MSF, the average delivery cost per person per round was estimated at 0.63. In contrast, the 6 districts supported by the National Malaria Control Program and commercial partners, UNICEF, actually cost range from 0.29 to 0.36. Because actually MSF, they brought in a lot of international experts to support the process. Well, as I earlier mentioned, the planning was not really done to actually provide or cater for the pregnant woman. Even the Ebola response. So after the MD, MSF actually established a specialized maternity Ebola treatment center at Hastings. That was in January. and it was actually closed when Ebola was actually declared over in November the 8th, to be precise. So total number of 72 suspected obstetric cases were actually admitted. 8 were EVD confirmed, because the case definition was to be unique. The one for usual Ebola cases was quite different from pregnant women. Then 19 tested malaria RDT positive, 2 had co-infection, EVD and malaria, total of 7 deaths, 4 actually died of Ebola, 3 deaths reported due to malaria. 4 EVD positive cases were actually cured and discharged, but fortunately 2 had abortion and 2 delivered stillbirths. All mothers were tested negative, were put on systematic treatment as per the protocol, and EVD confirmed were actually managed as the EVD protocol prescribed. So lessons learned. The joint planning and better coordination among partners at all levels was very critical, because actually we had one plan, one coordination, and one M&A. Social mobilization and community engagement was really critical. Use the media and other approaches gave high awareness about the MD and the extinction with Ebola and malaria. The use of paramount chiefs, other opinion leaders, councillors who are part of the community gave confidence to beneficiaries for acceptance of the MD and high uptake of the medicines. They have got a high demand of the drug. People are actually moving from the non-MD chiefdoms or districts to the MD areas, because they don't want actually to get fever and be taken to the holding centers. So the challenges we had among challenging to do MD in a time when the community had as apprehension and mistrust in the health system was really challenging at the initial stage. Underestimation of target population, that actually gave us a bit of challenge, especially during the first cycle. We actually missed out a lot of people because of the underestimation. People, of course, moved from the MD, non-MD to MD chiefdom, as I earlier mentioned. That strategy implementation was not adhered to in some densely populated areas, because the idea is people think they have to eat before they take the anti-malaria product. A mild adverse drug reaction in cycle 1 and cycle 2. Pregnant women were not considered for specific care at the beginning of the Ebola intervention until MSF actually came in and set up the specialized maternity Ebola treatment center in January. In conclusion, EVD outbreak was really an unprecedented crisis, posed enormous challenges on malaria interventions in particular and the health systems in general. The MD was a complex and challenging undertaking within the context of the world's largest Ebola epidemic. The experience proved that MD in an Ebola context is feasible and acceptable by the community. The activity acted as a complementary approach to contain the Ebola epidemic in Sierra Leone, while contributing to a decrease in morbidity and mortality linked to malaria. Pregnant women must be planned for and considered for specific care at the beginning of future outbreaks of Ebola or any high infectious disease. The experience can provide an interesting experience useful for other future outbreaks where quick reduction of malaria burden is actually needed. Acknowledgements to WHO for actually providing technical support throughout the process, and even the post-Ebola and also the rapid impact assessment of the MDA. UNICEF, of course, supported us, and also with coordination and procured the drugs, because they had stockpile of the ACTs in Copenhagen airlifted on time. MSF, Western area, urban and rural, the operational cost, and of course also procured the drugs for 60% of the target population. Global Fund reprogrammed, very difficult though, but we were able to convince them, and we got the commodities which UNICEF bought. Then of course UK DFID actually provided operational cost for the 6 districts, and World Malaria partner ALMA also actually had added value to the entire process. I thank you very much.
Thank you very much, Samuel. Are there any questions for Samuel? Matthew?
I don't have a particular question. Your presentation is really provocative. It makes me think of how we prepare for future events. In a sense, do we pre-position or be pre-prepared administratively, organizationally for having MDA drugs available for a similar response in the future? I mean, it's quite important, the fact that you had wrangling with Global Fund. Let that be a lesson and not happen again. Questions are for pregnant women within the Ebola context. Are pregnant women more susceptible to Ebola infection? So it's just a general question, as is the case with malaria. Is co-infection, just having an asymptomatic, perhaps, malaria infection become a symptomatic infection when co-infected with Ebola? These are multiple questions, but I'm just wondering how you might reflect on kind of the interplay between the infections themselves.
More questions while...
Thank you for the presentation. Given the Ebola context, wherein one of the symptoms of Ebola was like vomiting or so forth, did you ever experience refusal of your drug, given the fact that the ACT, the ASAQ, sometimes cause vomiting and weakness in some patients?
Important question. More questions? I just had one for clarification. I didn't understand, Samuel, how did you exclude pregnant women? You said it was doing pregnancy tests in the community? Is that? No. I didn't say that. Okay. Well, you answered the other two.
Okay. After no pregnancy test was done, it was really because the no-charge policy was actually in play, and the body fluids was really at high risk. Mm-hmm. So the first question basically relating to a co-infection, malaria, and Ebola in pregnant women. The point is, what we realized was the case definition that's actually established and the SOP that came out for pregnant women, it was a bit unique. So some of them, they had no sign of Ebola. But along the line, when some of them delivered, they bled, they tested positive. So it was very challenging. So that actually created a really tough challenge for the healthcare workers working at obstetrics unit, in a sense. They had to leave pregnant women unattended because they were scared. And the SOP was very clear, especially for invasive procedure. If it's confirmed, don't take the patient to a theater. So it was very pathetic, indeed. Really pathetic situation. Then, of course, in January, MSF had to establish, because initially, people knew very little about Ebola. But along the line, from experiences, they actually set up a specialized maternity Ebola treatment unit. And the outcome was marvelous. Then regarding the adverse drug reaction, we actually collaborated with Pharmacy Board. So pharmacovigilance monitoring was actually in place. And like for cycle 2, 556 out of 3 million people targeted for the distribution exercise actually developed ADR, very small percentage. And quite a lot of them was actually mild. So they was assured to take a lot of fluids. That this is a common type of reaction, it will pass off, but the compliance was really on the high side comparatively. But Pharmacy Board actually drilled further. We realized that compliance in terms of taking the 3 cause was not in place. Some actually took up to 2 days, they left, among others. So it was very challenging. But the second phase, when we strengthen the awareness creation, the benefits of the MDA, actually the compliance actually increased compared to cycle 1, which was about 72% and 83% in cycle 2.
Okay, thank you. Any more questions for Samuel? Elaine?
Just a really, it's not a question, it's a comment. I just want to remark on, this is so remarkable. The achievement of this MDA campaign under the circumstances with the Ebola virus is just really amazing. So much to learn from it on so many levels. So a lot of kudos and applause to your leadership and all the partners that worked with you. Really remarkable.
Thank you.
No more questions? Okay, thank you very much, Samuel.
Thank you.